part 2 of Mauricia's talk on local anesthetics, pharmacology applications, and regenerative medicine injection therapies. So Mauricia graduated with a Bachelor's of Science in Food Nutrition from Appalachian State University, currently a fourth-year medical student here at SCNM in the regenerative medicine honors track. Previously, she was a board member for the AZNMA Scientific Advisory Committee. Her areas of research consisted of regenerative medicine, essential oils, microbiology. She's also done research in essential oils, wine properties, exercise science. Her medical interests are in pain management and botanical medicine. So without further ado, Mauricia, I will let you take it away.
Thank you, Daniel. So for those of you that were able to make it last time, we discussed the differences of local anesthetics and toxicities and how that related to each other. And today we're going to continue that talk. But if you did miss that talk, you can access it on my YouTube channel at Naturopathic Pain. And I also think Sports Med Club has it here on the Sports Med Teams page. So you can contact one of the board members if you don't have access to that too. So without further ado, today we're going to start off talking about prevention. So now that we understand local anesthetic toxicity, how do we recognize it? How do we prevent untoward side effects from happening altogether? There are many measures that you can take that will decrease your chances of having to manage a local anesthetic systemic toxicity adverse reaction, also known as LAST. First thing to know is which patients are at the highest risk for local anesthetic toxicity. If you choose to use local anesthetics with your patients, it is recommended to use the lowest effective dose to achieve your desired result. When possible, do not do blind injections, especially in the spine or cervical region. Use guidance like ultrasound or fluoroscopy. Using incremental or slower injections to allow time to see if there is a toxic reaction is another thing you can do. And aspirate the needle in at least 2 planes, not just 1. You also may consider doing an intravascular pharmacological marker like epinephrine to determine if you're an intravascular or not. And we'll talk about that a little bit more in detail a little later. Continually communicate with your patients during the procedure. Make sure that they're not experiencing any of the toxic symptoms. So don't get lost in your procedure and don't communicate with your patient and see if there's actually isn't anything else going on with them. So each of these steps will only help you prevent local anesthetic toxicity so much. But if you're prepared for local anesthetic toxicity, you'll be able to quickly respond and avoid life-threatening situations. And that's what we're going to talk about here today. And so let's go into all of these here a little bit closer. So the first thing is which patients are at higher risk for local anesthetic toxicity. And here you can see those listed out. So the first risk factor are people who are either young or old. Elderly patients are more at risk due to increase in comorbidities, decrease in circulation, and decreased organ function. Younger patients have a lower body mass and lower levels of AAG, which we talked about in the last lecture, which increases the amount of free local anesthetic. Pregnant patients also have a decrease in plasma proteins, causing an increase in the amount of free local anesthetic. They also have high cardiac output. Patients with comorbidities of kidney, liver, and heart causes a decrease in elimination and/or metabolism, which they will also be at higher risk. Hepatic dysfunction or a decrease in hepatic blood flow causes a decrease in plasma proteins and hepatic clearance of local anesthetics. Low cardiac output will cause drug accumulation and reduce clearance. High cardiac output, on the other hand, can cause an increased gradient for vascular diffusion and absorption. A reduction in plasma proteins or a decrease in protein status can also cause an increase in free or active fraction of local anesthetics. Beta blockers, digoxin, calcium antagonists, cytochrome P450, or medications that inhibit sodium channels should also be avoided. Other risk factors include small patient size and acidosis. So one method to prevent local anesthetic toxicity is using small incremental doses of local anesthetics and see if there's a toxic response. The recommendation, according to the American Society of Regional Anesthesia and Pain Medicine, the ASRA, is to administer 3 to 5 milliliter doses at one time, and the length of time to pause between intervals should be about the time it takes for the local anesthetic to circulate once through the body, which is about 30 to 45 seconds. If you choose to do ultrasound-guided injections, you can use a lesser interval of about 15 to 30 seconds between injections. Another commonly used method to prevent LAST is needle aspiration. And a lot of people rely too much on this to be like, oh, I'm not intravascular, and you'll actually be surprised in how unreliable this method is. So when you aspirate a needle, you can have something called a false negative. A false negative would be when you pull back on the syringe and there's no blood return, even though you're inside the blood vessel. One mechanism that could cause this to occur is the needle is against the blood vessel wall, and the needle sucks in the wall instead of the blood. One way to help decrease false negatives in this case would be to aspirate the needle a second time after rotating the needle 45 degrees. However, remember, you may still have false negatives even aspirating in 2 planes, like we saw in that case, the cerebral toxicity case in the last presentation. That practitioner aspirated in 2 planes and still had a local anesthetic toxicity reaction. So it's not a fail-safe. And something else that you can look at to make sure that you have less false negatives is looking at the needle size or the needle gauge. The gauge of the needle refers to the thickness of the needle, and the higher the number is, the smaller the needle is. The lower the number, the larger the needle is. It is recommended to use a needle gauge 25 or below for proper aspiration. In comparison, a 27 gauge needle provides relatively similar results. However, a 30 gauge needle has a higher incidence of false negative aspirations. And the reason why is because the higher gauge needles provide a smaller opening, causing more resistance to flow. So you might be asking yourself, how often will a needle aspiration be accurate? A study conducted using fluoroscopic guidance with contrast to determine incidence of intravascular penetration during a transforaminal cervical epidermal steroid injection was done. According to this study, blood was observed in only 5.9% of the time the needle was in an intravascular space. That means that more than half the time a needle aspiration was done, you get a false negative. And as you can see here, another study looked at a lumbar transforaminal epidermal steroid injection under fluoroscopy as well, which showed a flash in the hub 44.7% of the time the needle was intravascular. And both studies, the specificity of needle aspiration was at 97%. That means that if you did see blood in the hub of the needle, then you were most likely in an intravascular space. So these 2 studies show us that roughly 1 in 2 times that blood is in the hub, there's no blood in the hub, you are in intravascular space. So that's not very reliable if 1 in 2 times you're in intravascular space, but there is no blood in the hub. So the recommendation is to pull back on the plunger for at least 5 to 10 seconds in 2 different planes to help reduce those false negatives. But even still, it is not an accurate means of predicting if you're in intravascular space or not. So there is another way to prevent local anesthetic toxicity, and that's something through intravascular markers. Before doing this research, I had actually never heard of this being done in regenerative medicine, but it is an imperfect technique that if you wanted a little additional information, if you were unsure where you're at, or if you were in a high-risk area that you wanted to be sure that you weren't in an intravascular space, you could inject something like epinephrine. And in an adult, you would inject 10 to 15 micrograms per milliliter of epinephrine, and you would check their blood pressure and heart rate for an increase. And if there was more than 15 of an increase in blood pressure or more than 10 in heart rate, then that would indicate that you were in intravascular space. Some contraindications for using this method would be beta blockers, active labor or advanced age, or general neural axial anesthesia. So now that we understand toxicity, understand how to prevent them, you could do everything right, prepare, and yet something unexpected happens and your patient has a last adverse event. So let's talk about how to prepare for that. There are 4 main steps to manage local anesthetic systemic toxicity that have been highlighted by the Association of Anesthesiologists of Great Britain and Ireland, the AAGBI, in 2010, and the American Society of Regional Anesthesia and Pain Medicine, the ASRA, both of which have recommendations that fall generally under these categories. And I've combined recommendations from both of these organizations into these 4 steps. So the first step is recognition, 2nd, immediate management, 3, treatment, 4, monitor and follow up. So the first step is recognition. And recognition is probably one of the most important steps in the treatment process, because if you're able to recognize the early stages of LAST, you may be able to prevent catastrophic patient outcomes. You can check the patient's vitals throughout the process, pulse oximetry, blood pressure, and possibly EKG if you're able to do that throughout the process to clue you into signs of toxicity. There is variability in LAST presentation. However, usually CNS symptoms will come first before the cardiovascular symptoms come. The cardiovascular system is more resistant to local anesthetic toxicity. The prodromal symptoms that we've talked about a lot at in the last presentation is agitation, auditory changes, metallic flavor, altered taste, numbness, lightheadedness, abrupt onset of psychiatric symptoms. And the onset time can be variable. So, for instance, it could be immediate in less than 15 seconds, and that means that you are directly in you are intravascular. However, symptoms could be delayed from 1 to 5 minutes if you're intermittently doing an intravascular injection, if you are redirecting the needle and going in and out of intravascular space. It could be in a lower extremity injection or delayed tissue absorption. But even with all that said, you can still have toxicity symptoms 15 minutes or greater after the injection is complete. So it's important to monitor a patient for at least 30 minutes after procedure to ensure there are no adverse events. So after you have recognized that this patient is having a last adverse reaction, the first thing you do is you stop the injection, you place the patient in a safe position in the event that they lose consciousness, call for help, and get a crash cart if you have one. If the patient is not having a cardiac arrest, you want to provide 100% oxygen via a bag mask. And the reason why you want to provide a bag oxygen is because if the intravascular injection causes cerebral toxicity, they can lose their respiratory drive. But if they are in cardiac arrest, you want to just go straight into the ACLS protocol. So another reason why you want to focus on doing the 100% oxygen is because if you're able to restore their oxygenation and ventilation fast enough and prevent hypoxia and acidosis, you can prevent the progression of the last adverse event to cardiovascular collapse or seizure and help facilitate the resuscitation process. And at this point, if it is under your scope of practice, you can go ahead and do intravascular or intraosseous access. In the event that they start to deteriorate fast, you already have that in place to go ahead and move on to the next part of your protocol. So now that you have the initial management, there are some different scenarios that can come up, and you will use the different scenarios depending on what your scope is, what available resources you have, and how the patient is presenting. And so that could be acute cardiac life support, ACLS. You could do intravenous access, which we talked about, cardiopulmonary bypass, seizure management, lipid emulsion therapy, and sodium bicarbonate. So this is on the right here, you see the ACLS protocol. And so when you're dealing with a local anesthetic toxicity, this is not a typical emergency situation, and the ACLS protocol was not designed for this. So there's certain adjustments that need to be made to the ACLS protocol because of the etiology of their cardiac arrest. No additional lidocaine should be given because it's an as an antiarrhythmic, or epinephrine should also be given at a reduced dose. Epinephrine is highly arrhythmogenic and can exacerbate their condition. Studies have shown that bupivacaine-induced asystole had poorer outcomes when provided epinephrine instead of lipid emulsion. The standard dose of epinephrine is 1 milligram every 3 to 5 minutes. The recommendation is to provide a lower standard dose between 10 and 100 microgram bolus that would be calculated at 1 microgram per kilogram. If ventricular arrhythmia does occur, amiodarone is suggested at the standard ACLS dosing. Also, the following medications should not be given: procainamide, vasopressin, calcium channel blockers, and alpha adrenergic receptor blockers. If a patient begins to experience cardiac compromise, it is important to call ahead to the nearest facility with cardiopulmonary bypass. Now, all facilities offer cardiopulmonary bypass, and there's a considerable wait time to starting it. So make sure that you're aware of who does provide that in your area, so that way you can go ahead and activate that and make sure that when your patient does get to the hospital, that they're able to provide that quickly. And the reason why you would use cardiopulmonary bypass is because there's an inadequate response to epinephrine or other therapies, and this is used as a bridge therapy until the local anesthetic is able to be cleared from the patient's body. So if things do progress to a seizure, benzodiazepines are the preferred medication because they have limited potential for cardiac depression, or the ones that do. So midazolam is the first line benzodiazepine that would be chosen. And you would usually dose between 1 to 2 milligrams via IV. However, if IV drugs are not in your scope of practice, you may want to provide IM midazolam. And I couldn't find an exact amount of how much to prescribe in the last adverse event, so I looked up what it was for status epilepticus if IV access is unavailable, and that's what this dosage is here. So it's 10 milligrams once, or 0.2 milligrams per kilogram, and the max dosing for that would be 10 milligrams. And sometimes benzodiazepines are not as effective as they need to be to halt seizure activity. In this case, you would use succinylcholine to decrease muscle activity and to prevent further acidosis and hypoxemia. However, this should only be done after airway with intubation and ventilation are secured, and this is not something that is part of our naturopathic scope of practice, so this wouldn't be something that you would be able to do unless you had specific training for that. There was no specific dosage that I found for succinylcholine for LAST. However, to prevent neuromuscular blockage, according to UpToDate, was up to 3 to 4 milligrams per kilogram IM with a maximal total dose of 150 milligrams. And if benzodiazepines are unavailable, the next best medications would be propofol and thiopental. And there is caution to be used with these medications. This is the reason why they're secondary, is because they can worsen existing hypotension and cardiac depression. And that's why benzodiazepines are the preferred for this. And so you want to use the lowest effective dose to manage the seizures. So for IV propofol, the recommended dosage is 1 milligram per kilogram. And that is the lowest effective dose that has been shown to subside local anesthetic toxicity. Thiopental given IV dosage is recommended at 50 to 100 milligrams via IV. And Also, something else to consider if a patient does have severe acidosis, something else that you can use to help prevent a further decrease in respiratory drive would be adding some sodium bicarbonate. And you can do that by 2 to 5 milliequivalents per kilogram via IV. So another therapy to consider is lipid emulsion. Lipid emulsion has shown good results in managing last adverse events. The lipid emulsion therapy works by attracting the lipid-soluble local anesthetics from tissues, improving CNS and cardiovascular toxicity symptoms. And by choosing a lipid emulsion therapy as your primary course, it simplifies your entire procedure because you don't really need a lot of the other pharmacological agents unless things progress to be more severely. But lipid emulsion therapy has been found to be very effective in treating local anesthetic toxicity and has been shown to be used in preference to benzodiazepines if it is used early enough to treat seizures, specifically to local anesthetics. The initial dose would be 1.5 milliliters per kilogram of lean body mass of 20% lipid emulsion, followed by a continuous infusion. The infusion should be at a rate of 0.25 milliliters per kilogram per minute, continued for 10 minutes after hemodynamic stability is attained. If there is failure to achieve stability, an additional bolus should be provided along with an increase in infusion rate to 0.5 milliliters per kilogram. The upper limit for lipid emulsion therapy is 10 milliliters per kilogram for 30 minutes. And just so you know, a lot of the things that I've looked at, lipid emulsion therapy seems to be the standard of care when it comes to last adverse events. And however, even though it seems to be such a great therapy, there are some possible side effects that could occur with lipid emulsion therapy, even though that they don't happen very often, which are listed here as acute kidney injury, cardiac arrest, venous thromboembolism, hypersensitivity, fat embolism, fat overload syndrome, pancreatitis, allergic reaction, and increased susceptibility to infection. And finally, after all patients receiving local anesthetics injections, they should be monitored for 30 minutes. And this is because the onset time for local anesthetic toxicity may begin 15 minutes after the injection. Also, if they had any signs of a last adverse event, you can still have cardiac depression persist long after the treatment. So they should be monitored for at least 12 hours after any signs of cardiac toxicity. And so after doing all of the research with this, I wanted to figure out what is it that I can do as a naturopathic physician in managing last adverse events. And it was actually a little bit disappointing because a lot of the things that would be the most effective in treating local anesthetic toxicity is actually out of our scope of practice. So I was talking to some different doctors, and even though we can do IV nutrition, we're not able to do IV or IO medications, even if we have the ACLS training. And that seems to also include lipid emulsion therapy. And so what do you do if you're not able to do those? And that's kind of why I highlighted out some of the IM approaches and other things like that you can do that are within our scope. So even though we can't do IV midazolam, we could offer IM midazolam. So keep in mind those different things. And something that I was looking at is, well, if I can't provide it with the training I currently have, what can we do in order to get that training? And so I was looking at EMT trainings, and this right here on the right is a chart that lists out what level of training you need in order to provide these different services to your patients. So for instance, if you wanted to do intravenous medications, you can be an EMT basic with some specialized training, and you can offer intravenous medications. and that's a 2-week course here in Phoenix. And I haven't looked at it too specifically, but I think that would then allow you to add lipid emulsion therapy and the IV midazolam and things like that to your repertoire in order to be safe when you're providing injections to your patients. And if you wanted to be able to add the interosseous medications, then you would need an advanced EMT with specialized training. Okay, so now that we talked about toxicity, how to prevent it, and all of that good stuff, I'm sure this is the part that a lot of you have been waiting about, is how does all of this come together to apply to regenerative medicine? And so let's go and talk about that a little bit more in depth. So this first study, amide type, local anesthetics, and human mesenchymal stem cells, the clinical implications for stem cell therapy, reviewed the effect of 4 different amide local anesthetics, ropivacaine, lidocaine, bupivacaine, and mepivacaine, on human mesenchymal stem cells. They used amide local anesthetics tested at 3 different concentrations of stock solution, 12.5%, 25%, and 50% at various times, 40 minutes, 120, 360 minutes, and 24 hours. So this kind of breaks it down here for you. You can see a chart here with or I guess more so the graphs here on the right that shows the different times. So you can see by looking at these that local anesthetic is time dependent as well as dose dependent. The longer the time stem cells were exposed and the higher concentrations of local anesthetics used resulted in an increase in stem cell death. The first set of graphs shows the results after 40 minutes of exposure. Apoptosis or cell death of the human mesenchymal stem cells was only evident following treatment with bupivacaine at 50% of the stock solution. The second set of graphs showed results after 120 minutes of exposure. Cell death was noted for bupivacaine at lower concentrations of 25%. Lidocaine, bupivacaine, and mepivacaine showed significant apoptosis at 50% of the solution. The third set of graphs shows results after 360 minutes of exposure. Cell death was noted for bupivacaine at a lower concentration of 25%. Lidocaine, bupivacaine, and mepivacaine showed significant apoptosis at 50% of the solution. The third set of graphs show results after 360 minutes of exposure. Bupivacaine reached a significant increase in apoptosis at the lower concentration of 12.5%. Lidocaine, bupivacaine, and mepivacaine showed significant apoptosis at 25% of the solution. So in all 3 graphs, ropivacaine treated cells did not significantly differ from the control in any of the concentrations or different exposure times. So this shows us that ropivacaine in this section had the best effects or the best outcomes. So now we can look after a longer period of time, after 24 hours exposure, and the viability of the cells were assessed. At 12.5% stock solution concentration, the cell viability for saline was about 94%. Ropivacaine was 85%, lidocaine was 77%, bupivacaine was 43%, and mepivacaine was 77%. The cytotoxicity overall from least to greatest was ropivacaine, lidocaine, mepivacaine, and then bupivacaine. As you notice, the greater concentration of local anesthetic stock solution goes, it causes a larger decrease in cell viability. The difference of cell viability from saline to ropivacaine was not a significant finding. So saline had 94% viability, as what ropivacaine had 85% viability at 12.5%. This was not statistically significant. However, if you're looking at this just for what it is, it could be posed as an argument that 10 to 12.5% would be recommended because 94% versus 85% could cause significantly better results in your patients if you had less ropivacaine in your solution. So we learned from this study that higher levels of lidocaine solution, 25 and 50%, showed significant loss in stem cell viability with lidocaine, bupivacaine, and mepivacaine. Ropivacaine showed significantly better cell viability compared to the other 3 local anesthetics at all 3 concentrations and time exposures. Cell death was time and dose dependent. The study postulated the mechanism this occurred was because of depletion of intracellular calcium stores and dysregulation of calcium signaling. So this next study that we're going to look at together, inhibition of chondrocyte and synovial cell death after exposure to commonly used local anesthetics, looked at the effect of local anesthetics on chondrocytes instead of stem cells. So this study looked at 3 different amide local anesthetics, ropivacaine, lidocaine, and bupivacaine, on chondrocytes at different time intervals. This study was consistent with what we saw in the last study with stem cells. Bupivacaine was considerably more chondrotoxic, ropivacaine was the least chondrotoxic, and chondrotoxicity was significantly increased with more exposure time. For the most part, ropivacaine outperformed lidocaine. There was an outlier at the 30 minutes where cytotoxicity decreased after 30 minutes. However, with ropivacaine and compared to lidocaine, however, there was a larger standard error bar. So this is saying that the lidocaine was less chondrotoxic at the 30-minute mark versus ropivacaine, but there was a much higher standard error bar here that you can see. So another thing that I wanted to look at was epinephrine. So when I was looking through the research to find a solution to reduce toxicity of local anesthetics in regenerative medicine procedures, and I thought because epinephrine can reduce the dose of local anesthetic use, that it could also decrease the cytotoxicity related to it. And it does this by acting as a vasoconstrictor, reducing the blood flow and systemic absorption of the local anesthetic. So theoretically, you would lower dose and reduce cytotoxicity. In this study, it also had epinephrine as one of its variables, and epinephrine alone was found to be one of the highest agents to cause cytotoxicity. So this would not be an effective method to reduce cytotoxicity, even though you would be able to use less local anesthetic in your solution. So there are 2 different types of cell-related death, apoptosis and necrosis. And we're looking mostly at apoptosis. So apoptosis is regulated cellular process that occurs because of trauma, toxins, cytokines, and pathogens. Apoptosis requires the activation by proteolytic enzymes called caspases. This study also utilized the inhibition of caspases to see if there would be a decrease in cell death of chondrocytes in synovial cells exposed to local anesthetics. It was found that the addition of caspases significantly reduced apoptosis after local anesthetic exposure. From this, it seems that caspases are a promising therapy for regenerative medicine. And just to kind of a side note for that, one of the other participants was mentioning using peptides to help with local anesthetic toxicity, specifically with bupivacaine, and I wonder if that would also help with cytotoxicity. I'd like to look a little bit more into the research with that. Okay, and so this next study that we're going to talk about, pharmacological caspase inhibitors. So it seemed like it was a plausible therapeutic approach, but is something inhibiting caspase is something safe to do, and so that's what this study explores here. So there is limited research available on caspases, and there are various reasons for that. and challenges. Currently, peptide inhibitors of caspases have poor bioavailability, cell permeability, and metabolic stability. This poses a challenge to isolate their structures and modify them for research. The safety of caspases is also a big question. So two caspases, GS9450 nivocasen and VX740, have shown to have liver toxicity in animal studies. However, VX765 passed safety studies but was not effective in epilepsy patients. The previous study we reviewed showed promise for caspases in regenerative medicine, but no clinical trials have been done to support its safety and efficacy in regenerative medicine. So even though it shows promise, it is not something that we can use for better efficacy of regenerative medicine at this time. So this next study looks at the effects of lidocaine and procaine on microRNA expression of adipose-derived adult stem cells. And so it looks at lidocaine as well as procaine. So seeing how that difference of using an amide versus an ester local anesthetic. So microRNA is the non-coding RNA that inhibits the translation of proteins during gene expression of DNA. Measuring microRNA activity is an indirect way of measuring toxicity to stem cells. In the graph here, blue represents saline, red represents lidocaine, and green represents procaine. The x-axis represents all of the microRNA being tested, and the y-axis represents the level of expression of microRNA. You can see from this graph that the expression of green, which represents procaine again, was the highest out of all three groups. Procaine increased the expression of 32 microRNA, lidocaine increased the expression of 4 microRNA. This shows us that procaine had a significant effect on the stem cells compared to lidocaine. And so usually when you think of higher expression, you would think of that as being more of a positive thing, but in this case, it's actually a negative thing. The increase in microRNA expression results in downregulation of stem cell differentiation, decreased immunity, and increased upregulation of apoptosis. It is hard to make inferences when you're looking at all of the amide type local anesthetics with this study because we don't have a comparison. So we can't make a blanket statement about ester local anesthetics or amide type local anesthetics. This is specifically looking at lidocaine versus procaine. But we do see procaine is more cytotoxic to stem cells than lidocaine specifically. And also note that this is using adipose-derived stem cells. And so when we do adipose-derived stem cell injections, it's showing us lidocaine has a better response to procaine. However, when injecting procaine or lidocaine into a joint, the native mesenchymal stem cells may respond differently to the local anesthetics. So with that said, this next study, procaine and saline have similar effects on articular cartilage and synovium in rat knee. So this looks at when you specifically inject procaine into a joint, and this shows you what happens with that compared to saline. And this was actually a pretty impressive study. And it, like I said, comparing procaine to saline in an animal study with 20 male rats. The saline group is on the left, the procaine group is on the right, and so A to E, saline, F to J, procaine. And there was no difference between the control and the experimental group here. The articular cartilage remained intact without having any erosions at all time intervals. This suggests that procaine is not chondrotoxic when injected directly into the joint. So now that you know how local anesthetics work, which local anesthetics or anesthetic would you like to use? Do you choose lidocaine because it has the fastest onset time? Will you use ropivacaine because it's the least cytotoxic? Will you use bupivacaine because it is cytotoxic in scar therapy or things like adhesive capsulitis, or will you use Procaine for intra-articular injections, even though it has a propensity for allergic reactions? And you know that it increases stem cell cytotoxicity, but it's not chondrotoxic, according to that study. Or will you choose to use a combination of these therapies or local anesthetics based on their clinical presentation, because you know the pros and cons of each of these local anesthetics? And that is my goal with this presentation, is to show you the ins and outs of all of these different local anesthetics so that you can make a choice based on the clinical presentation and based on what it is that you want to do to be able to alter the local anesthetic based on that, and be safe while you're doing it. And another thing to consider is the toxicity. So now that you understand how local anesthetics affect toxicity in the periphery versus in the cerebral toxicity, are you going to always do blind injections, or would you consider also doing ultrasound guided or fluoroscopy guided injections? So now hopefully you can make a clinically informed decision as you use local anesthetics in your practice. These right here are my works cited, and I have those here for you if you'd like to delve into the research that I did a little further. And so thank you for listening to my presentation. I hope you learned a lot, and I'm happy to share this presentation as well as the last one. You can request a copy of the presentation directly to me on Instagram, and I also think that the Sports Med Club is offering that to people as it's posted on the Teams group here. And if you like my work and you want to see more of what more of the research that I do related to regenerative medicine and pain management, check out my my Instagram page here at Naturopathic Pain. And now I'd like to open the floor up to some questions. Okay. So I think that no one has any questions here today. Thank you all for coming, and hope to see you guys out there in practice.
Thank you so much, Marisha. And for those of you who weren't able to attend the entire presentation, like Marisha said, we are going to throw this up on our Teams page. Marisha, thank you so much for taking the time out of your day 2 weeks ago and this week to give this talk. I think it was very informative, and I know a lot of students can benefit from reviewing this information and going back and rewatching this. So thank you so much for doing that. I hope this was informative for you guys. A couple things that just want to point out. Mondays, we're still doing yoga with Annabelle. So from 5:15 to 6:15, if you'd like to join us via our Teams page, we're still doing that. And then additionally, if you guys still have some questions for Dr. Drew Timmermans, we are doing a Q&A session with him. I believe that's going to happen on the 24th of November. So you can check back on our sports medicine email that you get weekly and go ahead and submit any questions that you might have for our live Q&A. And other than that, thank you so much, everyone, for being here. This will be posted to our Teams page. And Marisha, we appreciate you.
Thank you, Daniel. I appreciate you all for having me.
Not a problem. Our pleasure. We'll talk to you guys later.